So I think I have for you an easier case. These are more financial disclosures, none are relevant to this talk. So let me share with you a case of a 24-year-old female. Here you see the OCT. I actually was contacted by a resident calling me. I was not at our main campus at that moment. And she was asking me, just look at the OCT. Can you tell me if this OCT is normal? It's a young patient. She came in because of visual disturbances. Right eye, visual acuity 20/50, left eye 20/200. So who thinks this is a normal OCT?
Anyone from the audience?
I would probably ask the question the other way around. Who thinks it's abnormal?
And what is abnormal?
And somebody volunteer what's abnormal.
What is abnormal? Microphone.
Very good. So I heard there is irregularity at the ellipsoid zone, so in the outer retina. So of course you are all experts. I will give you a little bit more imaging data. So you have here the wide field color fundus photography of the right eye. We saw also some irregularity of the inner surface, and you have an autofluorescence image. Is the autofluorescence image normal or not? You see there is increased autofluorescence in the center here. Regarding medical history, she is under cardiological, pulmonary, and orthopedic care. And of course, at that stage, you would say, okay, well, what is going on with the left eye? Because the left eye has a vision of 20/200. So can you show me the OCT of the left eye? And in the left eye, there was much going on in the anterior segment. So there is extensively corneal clouding. And when I was asking about the right eye, I was told, I've forgotten to tell you, but in the right eye, she had a penetrating keratoplasty.
So you're giving us some very helpful clues with corneal clouding. Even though we're retina specialists, we vaguely remember the differential. This change that if you come from Moorfields, you probably see it at the electrodiagnostics meeting, and the other systemic clues. So I think you've given us enough information, even if you don't know the specific diagnosis, the group of diagnoses that it should fall in.
From the audience, maybe? Someone from the audience?
So the suggestion was amyloid, so I think a deposition disease of some thing. So amyloid you're suggesting, a reasonable thought. Do you want to stand up and say that? Yes, MPS. And a specific one? Okay. So
Hunter syndrome?
Mucopolysaccharidosis, MPS, is a suggestion, an excellent suggestion from a colleague at the front. Anyone else, any thoughts?
I think we have here really leading experts. I show you the OCT of the left eye. We went back, and actually 10 years ago, at the age of 12 years old, this is the OCT of the left eye. Doesn't help actually that much. But we already heard about the diagnosis. I just want to mention again, there is not only in the center of the macula this hyperreflectivity or this thickening, it actually also spreads to the periphery. So you already heard the diagnosis. I give you some further imaging. So this, of course, is not a vascular problem, but it is an underlying systemic disease. So the eye acts here as a window for the underlying systemic disease. Multifocal ERG was normal, but when you look at the Gansfeld ERG, you have abnormal scotopic response, so you have a rod, probably more pronounced rod cone dystrophy. So we already heard the diagnosis. Adnan was already asking for which type of MPS this patient has, because there is a huge spectrum regarding the clinical phenotype of these mucopolysaccharidosis patients. This is a patient with a type 1, and even within the type 1 you have a huge range, especially regarding the systemic manifestation. You have a mutation in the ironidase gene, which leads actually to a reduction or even a lack of this enzyme, which is responsible for the degradation of glycosaminoglycans. So if you have a lack of this enzyme, you accumulate these glycosaminoglycans. It's already actually shown in the literature that you have this especially foveal accumulation or a deposition. Here I show you the different types. So our patient had a so-called Shire syndrome. And in this syndrome, this is a very mild form. Usually they don't show like any, let's say, severe systemic abnormalities. So also intellectually, they have a normal development. So you wouldn't see when the patient comes into your office that this patient has a systemic disorder. However, of course, there are like syndromes which have like many more severe associated disease. Our patient actually got stem cell transplantation, so the question is, how do you treat this patient? You can also give an enzyme replacement therapy, which was not the case. When we go into the literature, interestingly, when you look at MPS type 1 OCT findings, usually it's described just to have like this hyperreflectivity in the foveal center, but I hope I convinced you that in our case, it's really like a widespread disease. And we talked about follow-up, so we have quite a long-term follow-up, and what actually is striking that these deposition, they don't change. But just to mention, this patient didn't have an enzyme replacement therapy. So I just showed you a case where the eye is actually a window to systemic disease, and of course there is like a broad spectrum of these MPS disorders. This is actually a case of an MPS type 3. It's a Hunter syndrome. But again, you see actually this foveal deposition. No one clearly knows what is actually the etiology of this deposition. Are these, for example, not well resorbed photoreceptors? Are these really just glycosaminoglycans? Is the deposition intra or extracellular? So there are many questions which are needed to solve.
Anyone in the audience manage cases want to comment on MPS? Or co-panelists, any thoughts? Beautifully illustrated case. Anything else apart from MPSs that give you that broad ellipsoid zone region reflectivity? So in your differentials, anything else that will give you that? Any other deposition disorders?
What you definitely have to have in the differential is when you look here at the second case, at the Hunter syndrome. Usually you have like this perifoveal thinning, and you could have in the differential here hydroxychloroquine toxicity, where you have this flying saucer sign. So that would be for me in the differential.
Great. Fantastic. Great. Yes, thank you very much. And